You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. What happens when a bedside nurse with a dyslexic pattern recognition brain decides the answer to a broken hospital workflow isn't a new policy, it's a picnic? My guest today is Dione Rogers, a Chief Nursing Informatics Officer who spent decades in England's NHS turning around failing wards, not with top-down mandates, but with data, curiosity, and a willingness to look ridiculous in a parking structure surrounded by color-coded paper. We talk about why digitizing a broken process doesn't fix it, it amplifies it. We talk about the VOD model, visualize, optimize, then digitize. And we talk about what it actually takes to get clinical staff not just tolerating a digital transformation, but running toward it. If you lead a health system and you're about to implement something big, this conversation is worth your time. Plus, there's tea. Let's plug in. Dione Rogers, welcome to the pod. How are you doing today?
I'm very well, thank you, Craig. How are you?
I am doing well. Where do we find you? Where are you hanging out today?
So I am in my book nook, which is my little reading nook in my garden, which is in northeast England, in a little county. Well, it's a big county actually called Lincolnshire, and I'm right on the coast. So yeah, in my garden, in my little reading nook at the moment. I love to read.
And I have to say, I did not know that you were British. I can't even hear the accent. No, that's a lie. I did know that you were British. And so thank you for getting on the pod. It's much later for you than it is for me. I guess that's how time zones work. So I certainly appreciate it. We met at a conference, and I thought your history and your work was super interesting. I wanted to share it on the podcast. So can you give us a little bit of history, how you started and how you ended up where you are now?
Yeah, sure. Thank you. So I'm going to take you back to when I was 13 and arguing with my father sort of every weekend around what my career path might look like. My dad was from a very working class background, a car mechanic, but had a bit of an entrepreneurial spirit and kept saying to me, you need to go into computers. That's your thing. That's your thing. And I was like, no. I want to be a nurse. I don't want to sit behind a screen. So this was in the 80s. So screens were just emerging really. And we had endless rows. So ironically, fast forward 30 years and I end up as a Chief Nursing Informatics Officer. So actually we were both right and we were both wrong. But he passed 20 years ago. So it's kind of a nice thing for me to remember how it all started and that he saw that in me from a very early stage. So I started nursing when I was 18, just really wanted, caring, wanted to kind of do the right thing, be a good citizen, and actually loved it. It was a real privilege. I still am a registered nurse, so that was 33 years ago. I got my qualification. But over the years, really found a great passion in improvement work, found myself becoming really frustrated with inefficiency and actually the effect on staff and patients of that. So not the inefficiency per se, just the effect it was having on those working around me, working with me and myself. A busy working mum. And it was hard. There was a lot of inefficiencies. So I found myself in sort of getting picked for improvement stuff and ended up doing a project around patient flow, actually. That's where it all started, around patient flow in the around 2011, which was looking at how we use data in a chain of tasks around how a patient comes into hospital, this is an acute hospital, and how they move through the system. And actually, the bits of improvement weren't about the day of discharge, where a lot of the improvement projects, it was about reducing the waste in the system and finding out actually where the kind of true constraint was. And it blew my mind. it blew my mind at how inefficient the pathways were. And actually, we were just working on the wrong things. And so that really piqued my interest in the use of data, but the use of data for frontline staff, not just for reports or root cause analysis of where things went wrong. Actually, in the moment, how can we use data to better manage our patients? Because I was seeing a lot of patients deteriorating whilst in hospital because of being in hospital when they didn't need to be there. And that really spoke to me, and I couldn't shake it for a number of years. So I ended up becoming a Chief Nursing Informatics Officer about 7 or 8 years ago, and I haven't looked back.
Well, so I want to focus on something you said earlier and something that you just added. So you said that your dad kind of saw in you that you were a computer friendly kind of person and that technology might have been your thing even before you saw it. And then you had just mentioned that you were a nurse, being a nurse and doing nursing things. And then someone assigned you. Yes. Someone assigned you. So was that like just an accident, or was there another person who kind of saw that you were going to be able to take your clinical and operational skills and add them together with some analysis to actually move the needle?
Yeah, I think you're spot on. I think it's I wasn't self-aware about my analytical brain until a few years ago, actually. And it's always been other people spotting that in me. I became, before that project, I was a ward manager, and I could see very clearly inefficiencies in how the ward was operating. It was a ward that was really failing. And through the use of data, really, I turned the ward around within 12 months and actually won a leadership award. The chief executive invited me to his office. I thought, oh no, what have I done wrong? And he was actually like, I don't know what you're doing, but like, I used to just get complaints about this ward, and now I'm getting so many compliments. And it was that really then people started to spot that I could use data to really make improvements, and pretty quickly, actually, and quite simple stuff. No big projects, really simple things. Like, my staff were leaving about a year into a role. They were leaving, and so there was an incredibly bad reputation for that unit. So I started to look at the reasons why they were leaving, and actually they were being promoted. And so the story became very different around that. And we used that then to recognise that actually it was an area that gave our nurses a lot of support, a fast-track training programme, which meant that they could proceed quicker than on other units. And that then became a way that we could actually bring people in. And within 6 months, we were over-recruited and loaning staff out to other areas. So I think that kind of initiative and my analytical thinking, later it came out that I do have dyslexia. And so then it more kind of made sense why I could think in these very different patterns, really. And that's what people saw that I actually didn't see. I do now, but it took a long time, Craig.
Yeah. I think, what do they say? It's hard to read the label from inside the bottle sometimes. Yeah. And so you need someone who's kind of outside looking in. Well, so let's dig down into some of those specifics from the beginning. You had said that, you had seen a ton of inefficiencies in some of the wards that you were on. And I love that story about how it seemed like this must have been a horrible ward because everyone was leaving. And then it turned out, well, they were all quite good and they were being promoted to go through the rest of the hospital or the system. So sometimes things are not as they appear just with the data alone. So what were some of those inefficiencies and how did you kind of get things turned around in a year? So Dione, you had mentioned earlier that when you kind of started in one of the wards, you saw a lot of inefficiencies and problems that others necessarily maybe didn't see. And you were able to correct many of them in a short amount of time, like a year. And so what were some of those problems and how did you fix them?
So I started to look at, again, what the data was telling me. So one of the biggest complaint was around patients having lack of nutrition. So I observed what was going on. And it was falling to pretty much, you might call them nurse aides, we call them healthcare assistants on the ward. And so when the lunchtime trolleys come round and the tea time trolleys come round, these were really busy periods. And there was 3 staff on duty on an average shift, and they were trying to feed 30 patients, get the meals out warm, sit patients up. This was the same time as nurses were doing medication, and we had visiting, and it was chaos, and staff were doing their best. So I thought, how can we do this? So rather than being dictatorial, I took one person from each group, each profession, and we took them out for the day, and we looked at what was going on, really, and said, how can we make this better? Our patients need to be fed. We've got a wicked problem here. It's all happening at the same time. Kind of what do we do? And we solved the problem together, really. And so what we decided was, unless there was a catastrophic event going on, nobody on the unit was exempt from helping people have their food and drink at meal times. And so we called it flooding the ward. So just prior to the meals coming out, we would all go, including myself, if I was in meetings or office work, we would all go out and we would help sit patients up, make sure they were in a good position to eat. The tables were clear, and we all then went and dished out the meals, which took 5-10 minutes. And it meant then we could all go back to our duties. Nothing particularly was disrupted. And actually we stopped getting complaints, and people, it was such a great thing. And it was visiting time. And then our image, our reputation started to improve, because actually then when our senior staff were out on the wards doing this as well, it just gave a different image. It uplifted the staff, going, it's not just on us and we just keep getting berated because the complaints are coming out. Like it's just much more of a team effort. So I'm not sure where that thinking came from. It just made sense to me that was the right thing to do. And so then we took that in lots of other ways. How did we present ourselves in uniform? How did we present ourselves on the telephone? How did we answer the telephone? How did we welcome patients onto the ward? How did we make sure their property was looked after? So we started this cycle of improvements, but really as a collaborative. And I think that's just my style. And then I use data again, thinking about how we measured things. Somebody told me once, show me how you measure me, I'll show you how I behave. And that meant a great deal to me. So I then was really careful how I measured things and what the impact was. Because if people were doing their best, then it was up to me as a leader to find a way to do it differently, using some of the data and using some of the metrics. And that's one of the reasons I really looked at our audit program and said, is this adding value? And I think that's something that's become really part of who I am, is, does this add value? And what impact does it have? And I think my skills at looking at that and bringing people on board have really helped a lot of the improvement work that I've done.
So some of it is just kind of, I hate to use the phrase because it's kind of cliche, but thinking outside the box, right? Like, well, yeah. Sure, it's a busy time when we're handing out meals, but what could we do? We only have 4 people that could do that, and your answer was not a high tech one. Everyone who's available can hand out meals, no matter what their rank or tenure is, and it's kind of something that you often hear is, that's not my job.
Yeah.
And so how did you hear that? I'm assuming you heard it from someone. Mm-hmm. And then how do you respond to, that's not my job?
So I always brought it back to them personally. And this was the hospital that cared for their family too. Mm. And how would they feel if their family member came in and hadn't had basic needs? Eating and drinking, being warm, being clean are basic human rights. So shouldn't we be getting that right? And actually, the question that I asked them to reflect on is, what do you want people to think of you when you say you work on this unit? Do you want them to say it's a unit that gives poor care? Regardless of how hard we're all working, that was the message people said about that unit. And I didn't see that in the people that were working there. I saw really good people. but the reputation was terrible. And I said, so, if someone says, oh, I work on this ward, what do you want them to think? And actually, we're measured by the basics. We're actually measured by that. So I want you to be thought of as a great person giving care, because I don't believe anyone goes into care without wanting to do their very best. So yeah, just being human, I think, just talking to them and saying, my family are treated here. I want them to know that they're going to get the basics and we're going to do our best.
Yeah, that makes sense. I certainly think many clinical folks who have never spent a day in the hospital as a patient or have to engage with the system as a patient, it's difficult sometimes to kind of see everything from the patient's perspective, unless it's you or a loved one, and kind of bringing that back. Once you have that experience, it does make you want to provide the best service that you can. Well, let's talk about something that it was a 2-word phrase that you mentioned when we were preparing for this that I thought was awesome, and I think also kind of gives a good glimpse into how you practice, which is paper picnic.
Yes.
So I have to be honest, I've never attended a paper picnic, but what was that? Why would I attend one, and how effective was it, or are they?
Yeah. Again, a little bit of an insight into how my brain works. I work very visually. So this goes back to around 2019, 2020. I'd just started in my CNIO role, and we were still on paper at the trust that I was working at, which was Kettering General Hospital, right in the middle of England. And we were still on paper. It was the trust that I trained in. And I could really see that we'd got a problem. We were being asked to digitise this, to put this into a new electronic patient record. And again, going out onto the wards and looking at how the staff were working, I was seeing some real burnout problems, some real inefficiencies. And the moment came when we saw some reports that our falls harms were going up. And the immediate knee-jerk from the nursing team was to redo the falls risk assessment. And so I'm thinking, why are we doing this? We've got a lot of data going in. We're not really utilising it. It's not really helping us to manage patients' harms. So why would we think that? Back to that again, is this adding value? That's the question I always ask. And the nursing teams ended up putting more data fields in to the paper that we were then planning to digitise. And I was like, I don't think this is going to work. And but I couldn't find a way to help people to see the big picture. And so I thought, I'm going to show them the big picture. We're going to have a look at this. So I was working with our EPR supplier and their CNIO, Jacqueline, and said, look, I've got a vision that if we actually put all the paper out on the floor and then started to have a look at what this meant in different ways, we're going to be able to see what we need to do. I genuinely believe that we will. And so I said, it's almost like a big picnic blanket. If we put it all out, I know there's going to be hundreds of different pieces of different coloured paper. Like, I think this is a picnic blanket. And it was in the middle of COVID when we started kind of in the middle of the second wave, and said, we're moving all this paper around. What does this actually look like? And we need to do something about this before we digitise it, because it's going to compound the problem. And so she managed to kind of work her magic to realise what my brain was saying. And we started then to come up with a concept of paper picnic, which was hiring a big marquee, putting it right in the middle of the car park, inviting all the clinical staff to bring their piece of paper that they were using, swim lanes. So one was assessments, one were care plans, one was referral, documentation, the whole shebang. I think we had 7 swim lanes. And if you brought a piece of paper that we hadn't collected yet, you got a little prize. You got a little bit of merchandise. And then around the edges, we had our staff from IT, our IT training team. We had our team that were trying to recruit digital champions in. And each stand then, if you engage with that stand, you got a piece of picnic food or drink. So at the end, we got some intelligence from you. You got to meet the teams who you're supporting the transformation, and you ended up with a nice picnic basket at the end, and you could go and sit with your friends for an hour and have some lunch and a chat. And of course, a feedback form on a little QR code on the picnic bag. So that was the start of the paper picnic. It's actually, I think about 20 trusts now in England have completed a paper picnic. It's been revered by the Chief Nursing Informatics Officer of England. And that work then started to inform the digital documentation standards that we're now seeing in the UK, because some really bold things came out. Like, there were 72 pieces of data required for an admission. And on paper, that meant 72 dates, 72 times, 72 signatures, 72 printed names before anybody started. And we worked out that if you actually completed all the data of an admission, it would take 2 hours. But we had about 15 minutes. The nurse had about 15 minutes. So we were completely setting our nurses up to fail.
Sure.
And then if we were going to digitize that, how do we do that? How do we get as much data in to that initial assessment without and using the great efforts of technology to actually reduce this down? So classic example is it date and timestamps and recognises who you are. So immediately those 72 pieces of information were gone with digitisation. But then duplication, how do we do that? We saw 12 forms, different forms of a behavioural chart. So 12 different variations. And then we were wondering why our social care colleagues and our mental health colleagues, when we were discharging patients, was confused with the data that we were sending out because we weren't standardised. So
Sure.
Then we made some decisions around standardisation before we digitised. So this then became a model called VOD, methodology, visualise, optimise, digitise. And that is now used by System C, one of the English EPR suppliers. And we've written up around this in the Nursing Times. And really, Jacqueline and I speak about this quite regularly to support people recognising that rubbish in is not rubbish out. Rubbish in is amplified when you digitise it. So that was kind of the vision of Paper Picnic, really, a little crazy idea in my head that's been quite impactful.
Yeah, well, I love you mentioned that VOD model: visualize, optimize, digitize. And the visualize part is something that we often miss, right? And we go right to trying to at least digitize things. And your point is we're making bad things much faster. So you can do more of those bad or unnecessary things, which I love. And your stories reminded me of a story from, I don't know, a long time ago, probably almost 2 decades ago, but it was a hospital that was moving from paper to an electronic health record. And I was called, as I was working for a vendor at the time, for the EHR vendor. And I was called down to see if I could help with this problem. And the problem was that the blood bank was refusing to send blood up to the floors because they didn't have a form that needed to be signed by the doctors. And for years, they had this form signed by the doctors, and they couldn't release the blood without that form. And they were on one side of the room. And the other side were the doctors who said, "We've never seen this form." That was difficult, right? And it clearly hadn't been digitized. And then ultimately, after some investigation, it turned out that the unit clerk, the secretary, had been filling out the form and signing the form for years. And so clearly, we had two sides that really didn't know what was going on, with an intermediary that was just trying to help the unit clerk. But clearly, that form didn't bring any value to anyone because it was filled out by the unit secretary. And so, without that kind of understanding about, hey, there are some workflows that don't make any sense. We do them. We don't need to digitize them. So that kind of first visualize, which again, I love the idea of being in a car park somewhere with just paper all over. And I can just imagine the lanes of, the workflow lanes, the swim lanes with just paper. And then, of course, I can also visualize people fighting over new pieces of paper that they can bring to the event. No, don't you? No, I found it. I'm bringing it. No, I found it. I like that. You're really incentivizing people probably for what was just a few pounds to get, a T-shirt or something.
That's right. And the beauty of it, I guess one of the unexpected outcomes was that we didn't have to point these things out, the inefficiencies, what we needed to do differently. People saw what they saw, and it was very different lenses. And they started to then form these special interest groups, these design groups that said, we're gonna sort that. So I didn't expect that, quite honestly. I expected, to be some realization, but it really energized people. And I read a book last month called The Power of Moments, Chip and Dan Heath. And that's what it was. It was the power of having a collective fun moment. Healthcare is very hard, very serious, and actually doing a bit of something out of the ordinary, a bit intriguing, a bit creative. But actually then there was a real output. And the survey that came out of it, we talked about what technology would be delightful for them. And delightful is a word that I absolutely love. And when you talk to technology, it's not a widely used word, but actually it needs to be delightful to make it work. Adoption is a non-existent thing if it's delightful. So, and the big thing that came out was I would love to be able to talk my documentation, and the system records it and puts it in. And now 6 years later, we're talking AVT all over the place. So, there was some really creative thinking there. And so that, it meant a lot that those nurses were already starting to think about transitioning to how technology could work differently for them. And that's my wish.
Yeah, well, it's, you had mentioned in some of your work that engagement of the clinical and operational staff is not a nice to have. It's essential if you're going to do a clinical transformation. And I think it seems to me like a great example, this visualization process of, hey, like what exactly are we trying to fix? We know we're trying to fix the system, but what is the system? And, having people kind of scrounge around looking for paper that needs to be either thrown away because it doesn't make any sense, it actually doesn't bring any value, or it needs to be somehow incorporated into our new digital workflows, kind of gets people engaged. Are there other ways that you've found to kind of engage, especially your clinical folks, that you think are underutilized?
So I think embedding digital into current processes. So we have a framework in the UK called Ward Accreditation. So Ward Accreditation is it's a really great initiative, generally led by the chief nurses, that looks at how the ward itself operates across a range of metrics. So rather than doing individual quality audits, they are assessed against a range of things. And so things like, again, their forms data, their complaints. But we added digital into this a couple of years ago, because what we were saying was digital shouldn't be something on the side. It should be that golden thread through what people do. And actually then, how do we get digital to be recognised as something that nursing staff in particular, being the biggest data inputters of healthcare data, kind of learn and embrace? And so we started to talk to them about, well, what would be the things that would really help you to collect the right data, to understand the right technology that your ward's going to be using, etc. So bringing those staff into those digital arenas, and what they started to do was come and present to us what they were doing around digital. And the biggest impact was their digital champions. So they started to nominate those people on the ward areas that were really interested, and started to then disseminate the learning that they were having on those ward areas, and then build it into an accreditation module. So in order to be a ward that got to gold, you had to have some really good digital champions. You had to demonstrate that you were engaging in the training, engaging in the use of data, that you were really thinking about how you could become more paperless, but not just for the sake of being paperless, for the sake of helping with your quality of care. And so they really helped, those wards really helped to shape it. And the pride when they got to gold, saying, you know, we're now starting to move into this digital era. And actually now, because it was all on Excel spreadsheets and things, and then say, we want this to be digitized. We want the system. We want the data to be digitized. How can we do this? You know, was a really good way, rather than saying, you know, you have to do this training. So I think embedding it in how the ward works and what they value, speaking to them, going to watch what's happening. I went on some wards and just took some pictures of the vast amount of folders and said, do you ever pick these up? How are the policies kept up to date in these folders? What would your ward look like if you got rid of all of this, you know? And people were like, because again, you don't see what's in your own site, do you, sometimes? So again, that visualization of going, do you see this and what can we help you to do about it? So I think that whole thing of being with them, going to speak to them, but not in a pushing digital or technology on people. It's finding those sweet spots that really can help them and help them to be proud in their ward areas and the care that they're delivering.
Yeah. So not technology for the sake of technology, but
Absolutely.
for actually improving the care that people can deliver and helping them to do it in a better way. So it works for them as well as for the patient. Yeah, that makes sense. And I love how you kind of frame that, which is what do you care about? Oh, you care about getting this ward certification. How can we incorporate this digital transformation into that so that you're really not working towards anything different than what you would have been working towards 5 years ago? It's still all right there.
And I guess one of the things that really worked, we ran a competition to design our Digital Champions logo. And one of the staff, we won that competition. It was kind of a superhero type person, but the role that I was in is in North East London, which has a hugely diverse workforce and patient population. And so they designed them with 5 different skin tones. And so they're very generic looking, wasn't male, wasn't female, but just different colours of skin. And so when we ran the paper picnic at that organisation, we had our Digital Champion stall. And you wouldn't believe how much people wanted to become a digital champion, to get hold of a badge that was the colour of them. And it was a great, but that again came from staff. It wasn't my idea. It came from staff. We incentivised the competition. And we then said, okay, what merch else could we promote? And the trust didn't supply mouse mats. So we then had a whole load of mouse mats made up with this character on. You could choose your mouse mat that identified with you. So things like that, again, a real great visualization. We banned notebooks and said, if we're going digital, you know, we're not having that merch. We're having really good merch and things that people really want. And we ended up having about 700 digital champions join off of that campaign. So yeah, it was great.
It worked. All right. Well, we're running low on time. I wanted to understand a little bit about what you're doing now. So you've been with the NHS for a long time, I would presume, and you've pivoted recently. So tell us about that.
Yeah, so I left the NHS officially on the 31st of March. I've started my own company called The Flourishing Hub. This is digital advisory and AI ethics advisory, alongside some coaching. I've just recently qualified as a coach as well. I'm very people orientated, as you can probably tell. And so that's a bit of what I wanted to do. So why did I do that? It was quite a sudden decision, really. And it was a moment of gut instinct, I think. I had this epiphany. I can only describe it as an epiphany. I had a couple of bereavements last year that were very difficult, and suddenly thought, what do I really want to do? Am I doing what makes me happy, what fills my cup? And actually, a couple of years ago, I completed a master's in AI and data analytics. And you can see my passion has been data all the way along. And now with the emerging AI platform, I'm like, we've just put in another EPR. We're nowhere near the role that I was doing actually fulfilling me. And so decided to gift myself a year of passion projects. So that's what I've done. I'm not looking beyond a year. I'm giving myself, and I think, going to the conferences that I went to last year, meeting, people like yourself, stepping out of my NHS bubble that I've been in for a long time, it felt just I needed to do this. And so I'm stepping into a bit of coaching, I'm doing some consultancy, and the big project that I have coming up with a few colleagues is healthcare AI ethics. So that's where my passion is sitting. So how do we get the data and the ethical framework right before AI really compounds healthcare? I do believe AI will really help healthcare, but actually we have to have that good data quality and those good ethical guardrails in to make the best of it. So I feel like this is the right time to do it. If I'd have sat in that job another couple of years, I think it would have passed me by. So I leapt and said, I'm going to bet on myself. I think I'm going to be okay. And I'm so far absolutely loving it. I'm very busy, actually. That's the biggest problem. I'm very busy, and it's kind of, where do I put my energies the most? But really, I'm writing some books, citing in some other books. I'm doing lots of things. But as long as they sit in my passion projects portfolio, I'm up for it.
Oh, that's awesome. That's very exciting for you.
Yeah.
Many of us dream about that and don't do it. So glad to hear that you've done it. Well, we are now at the point where we're going to I ask you one final question, and it's the same question I ask all of my guests. Is there something that is in your life that's so well designed it brings you joy whenever you interact with it?
Yes, and it's a very random object. It's a stovetop kettle.
Fair enough. Tell us more.
So we moved to the coast 2 years ago, and we decided my partner retired from the police and decided that we wanted to do something around having a small holiday let. So we invested in a hand-built, handcrafted shepherd's hut. So I don't know whether you have them in the States. They're kind of like a little cute tin and wood structure on wheels, a bit like a caravan, but not, much more classy and quite cute and whimsical. So we invested in that, and we decided we would go eco, and we overlook fields. We have a lot of wildlife, deer, owls and things in the field, and then the sea. So we said we don't really want to put loads of electricity into the area. So we have no TV in there, we have no Wi-Fi in there, and we have no plug sockets. We only have a stovetop kettle. And so I found this beautiful, my favourite colour is green, I love nature, this beautiful Le Creuset French stovetop enamel kettle, and it makes the most beautiful cup of tea. And as you know, we love our cups of tea in England. So at the end of the week, I go and make myself a cup of tea in this kettle and just switch off. So it's it does exactly what it's meant to do, makes a lovely cup of tea, looks brilliant, looks a really nice design, and kind of signs my week off.
I love it. Well, that's great. I had mentioned before we started recording that I'd taken a look at this particular model, and it is quite lovely. I wasn't able to find the green one, so I have to keep looking to see that particular shade of green. But well, that's awesome, and thank you for sharing that with us. It's one of my favorite parts of the podcast is understanding what makes people tick, and for you, it's a kettle that makes just a perfect quintessential cup of tea. So terrific. Dione Rogers, thank you so much for joining us, and good luck on everything that you're doing. And I look forward to kind of hearing back. We should check in with you from time to time to see how your adventures are progressing. Thanks again for joining us.
Thank you so much for the opportunity, Craig, and good to see you again.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Dione Rogers, follow her on LinkedIn or at her Flourishing Hub community. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. We'll see you again next time on Designing for Health. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.